I've been letting people into the waiting room, from the waiting room, but someone else will need to do that because I'm going to talk.
Okay.
I've been admitting people. So shall we start? Yes. Okay, so welcome everyone to this webinar and to the launch of the WHRIN Global Mapping of Harm Reduction Services for Women Who Use Drugs. I'm Lynette Collins and I'm a member of the WHRIN Advisory Committee, and I'm talking to you today tonight from Jakarta in Indonesia. For those of you who don't know us, WHRIN is the Women's Harm Reduction International Network. It was formed in 2009 and is led by women who use drugs. The goal of WHRIN is to improve the availability, quality, relevance and accessibility of health, social and legal services for women who use drugs. This global mapping reflects in many ways the core business of WHRIN, which is to understand what is the situation for women with regard to harm reduction. And it really began in the early days of WHRIN's life. Started organically as an ad hoc collection of case studies and other information exploring the barriers for women who use drugs to harm reduction and other services, as well as the impact of prohibition. From this base, the next step was to undertake a more formalised and systematic approach to documenting the information. The work, funded from within the WHRIN budget by 2020, was built into the work plan. So here we are. A global map of harm reduction services for women who use drugs, a consolidation of information from 54 countries and 8 regional reports. The regions are Asia, Eastern Europe and Central Asia, Western Europe, the Middle East and North Africa, East, West and South Africa, Latin America, North America and Oceania. It's been translated into 9 languages: English, Russian, Thai, French, Arabic, Swahili, Indonesian, Ukrainian and Spanish. Also included is a living listing by regions of the services with a brief description and links for more details where they're available. The information was collected using short surveys in 6 languages and desk review by WHRIN members, focal points and their networks. We do acknowledge that the mapping report is not exhaustive, but hope it will serve to initiate the charting and promotion of services for women who use drugs around the globe. This is a living document. It's accessible on the WHRIN website and the service listing can be updated. Instructions for updating are in the report itself. So, key findings. Let me start by saying that the mapping work and the results sit within a broader context of sexism and oppression of women, the legacy of colonisation, including dispossession of First Nations people and slavery, more recently discrimination against LGBT+ and other minorities. These are forces which continue to systematically marginalise and discriminate against all women, including and even more so women who use drugs. It's continuous and pervasive, and creates an environment that fails to recognise and support women, children and their communities. It's also important to note that the global spread of harm reduction services is stalling, a continuation of a trend first observed in 2012. Relevant UN agencies such as WHO, UNODC, UN Women have all acknowledged the need for women-sensitive harm reduction services. Sadly, to date, there has been no assessments of the gap between these endorsements and the reality of harm reduction services on the ground. So, to the findings. The global mapping is now posted on the WHRIN website and in the Zoom chat box, so I will only briefly discuss the findings. You can read them in full later. Responses were received from all countries contacted. In most, there was simply no harm reduction services for women who use drugs. This was particularly the case in Africa, Latin America, Eastern Europe, Central Asia, Asia and the Middle East. There was a clear disparity in the availability of harm reduction services for women between the global north and south. However, Even in the global north, no country demonstrated availability of services to scale. In addition to this, harm reduction services were absent where conservative governments and populist support of punitive drug policies was found. The key barriers to access by women who use drugs to harm reduction services were criminalisation of drug use and gender inequality. Women also experienced greater social and economic inequality than non-drug using women. Women who used drugs were victimised, judged more harshly and punished more harshly than men who used drugs. Examples of this included exclusion of pregnant women from harm reduction services and a global increase in incarceration for women convicted of drug-related crime. Other key findings were a lack of harm reduction services designed and implemented by women with lived experience of drug use. Harm reduction programs were often dominated by male clients. There were very limited times and spaces to accommodate women who use drugs and their children. A lack of women peer staff was also reported. Women who use drugs who were trans women, both young and older women, pregnant, experiencing gender-based violence, homeless, and who are engaged in sex work also lack access to existing harm reduction services. There's an urgent need for effective harm reduction and other essential health services in closed settings, such as women's prisons and compulsory drug treatment centres. A lack of political will from leaders to address all these issues was reported. It's clear from the needs identified in this mapping that there is no excuse now not to have harm reduction services for women who use drugs. We have examples, methods, training materials, and endorsement from global bodies. Expensive or no-cost adjustments could be made to existing harm reduction services to improve relevance and accessibility to women who use drugs. So that's it broadly, and that's enough from me. So let's hear from our panellists who will present in more detail the findings from 5 of the regions where the mapping occurred. These presentations will take around 40 minutes. After they're done, we'll open the webinar for questions from you, the audience. So sit back and enjoy. And I'll hand over the floor to Nandini from Asia.
Hi everyone, this is Nandini and I will be covering the Asia region today. I am from the community of women who use drugs in India, and so in Asia we have seen various reasons for why there are no women specific centers, and I'll just go into that now. So we received responses from 10 countries, out of which 3 countries have reported that there are currently women specific harm reduction services available. Sorry, Delta, I could see the screen. So the 3 countries, like I said, are India, Nepal, and Myanmar. Next slide, please. So here we can see on in Asia, we have these 3 places, and the type of harm reduction services that we have there are integrated with sexual and reproductive health services. There are services like family planning, pre-postnatal care. However, I'd like to specify that these services are currently in Myanmar, they have really made a good effort to have these services available, and if I pronounce that correctly. So where it is basically a women and children friendly space. In India, we have, in the northeast of India, we have drop-in centers for women. And so that is what we see in India and Nepal. However, if we look at the Philippines and Indonesia, we see that there are high levels of incarceration of women who use drugs. There is things like forced rehabilitation where, you know, they do not have any scientific base. They have lack of legal and social aid. There are it's quite often it is non-consensual and heavy stigma and discrimination. The stigma and discrimination part is something we face everywhere. And the treatment remains unregulated, and abuse of power by authorities is also a very relevant problem in the Philippines and Indonesia. As well as in India, we have like cultural, religious barriers that we have to overcome. And I would also like to talk about the examples. For example, in India, before we could have any women-centric services, it took a lot of dialogue and a lot of time before we could have that. So, and top 3 barriers that we have seen in the Asia region is kind of induced by the stigma and discrimination, the heavy criminalization of drug use, and the overall lack of harm reduction services with a woman-centric approach. And we have also noted that the current programs and policies are very male-centric, and we need to have more involvement of women in the creation of programs, policies, as well as at the ground level. Like in Myanmar, we have peer-driven outreach, as well as tools like social networking to identify more women who use drugs and get them get them registered or help them to access the services. And above all, stigma and discrimination is something we all face at every level. Thank you.
Thanks, Nandini. That's great. Could you, thank you very much for presenting the information. And as you're talking, I'm thinking, how do you think this mapping can be used? Do you think the results are useful and able to be, how could you see them being used?
Well, this is, we have not had something like this done before. So I think this is a very important milestone for us. Once it is like the first step towards, when we are working in the future and we want to present our case to a certain department or a certain authority, it's like we have some foundation on what we are basing our findings on. And this is directly from the community. So, we have a kind of a backup. We're not just going without any proof or any evidence. Mm-hmm. And I think it's very important because this is like the starting point of a very important and crucial matter that needs to be addressed soon. Mm-hmm. Very soon.
Okay, thank you very much. Our next panelist is Rita from Africa. So I welcome Rita.
Thank you very much, Lynette. Hello, everyone. My name is Rita Musa. I'm the National Secretary for the Drug Harm Reduction Advocacy Network, Nigeria, and I'll be presenting for African countries. The global mapping of harm reduction services for women in Africa, specifically West Africa, East Africa, and Southern African countries. The global mapping, we're able to get 12 responses from 12 different African countries. We have the likes of Burundi, Cameroon, Kenya, Madagascar, Mauritius, Mozambique, Nigeria, Senegal, South Africa, Zanzibar, and Tanzania. Now, of this 12 countries, we also had 8 countries who showed very little scale of interventions for harm reduction interventions specific to women who use drugs. Like, for example, we have in Tanzania and in Kenya, very small scale women's shelter. Women who use drugs shelters were provided with links to harm reduction services. We also have meaningful involvement in Mauritius and South Africa of women who use drugs in assessing services. Also, we had in Senegal, in Madagascar, Mozambique, sexual reproductive health rights were, designed specifically to target women who use drugs in these countries. Now, from this global mapping, we're able to bring out some factors that, were similar in the African countries, some barriers that were similar that African countries see when assessing harm reduction services for women who use drugs. Now, like earlier said, I'm sure Lynette pointed this out, and also Nandini before me, she made mention of the criminalization of drugs. In fact, it's not just in Africa, I think it's a global thing. Those were similarities we saw. Most African countries still had laws that criminalized drug use. And then we had the lack of, or rather a limited gender-specific harm reduction services, like earlier said, from the 12 countries, we had only 8 that had very little, very minimal skills, not even all the harm reduction practices, just very few were specific to women who use drugs. Gender-based violence and intimate partner violence, this is a norm in Africa and probably in all the globe. These are some of the limiting factors. This, because of the gender, the limitations placed on women, we know, coming out to assess treatment, women are usually the last to assess treatment, and even like we know for injecting drug users, they are the last on needles. They're even last as they don't go get the drugs themselves. They always wait or depend on their partners, male partners, to get those drugs for them. And so a lot of violence again are instigated towards women who use drugs. We have the cases of police brutality. We have rape even in the community. People always just there is this factor of, I'd say, the stigma, as we all know, it's like towards women who use drugs, and the fact that there's an assumption that any woman who uses drugs is assumed to be non-useful to the, cannot be useful to, the society. And we have the domination of existing services by male service users. Like earlier said, it's male are more conversant or more confident to go assess this treatment, and then we also have healthcare providers who are male. That's usually a problem for women, because women would rather have, like they would rather have females, women like themselves, to offering or being the healthcare providers. In that sense, there's that safety, and there's that, there's at least a reduced stigma when service providers are females also. And we have the stigma and discrimination, which is all around African countries, all around the globe, I would say. So from these factors, we're able to bring out some instances in Africa that were reoccurring. Here we have like policies and justice systems do not protect women who use drugs. Now, in African countries, we have some cases of politicians coming on air and making statements that discriminates women who use drugs, and based on assumptions, based on their lack of information, they just say a lot of things that changes that affects the public's perspective towards women who use drugs. We also have the inadequate funding for women who use drugs in harm reduction programming. Okay, let's say for African countries, very few that already have harm reduction practices, very few of them have specific interventions for women. The practices are not tailored to meet the specific needs of women. Now, we also have limited understanding of the gendered and also the general context of drug use. I said the gendered in the sense that women, the specific needs of women who use drugs are yet to be understood in these African countries, because probably there's no programming for them, probably there's no audience, there's no efforts towards trying to understand the needs of these women. And then the general context of drug use in itself is yet to be properly understood, drug use of drugs generally, and also of harm reduction in some African countries. So from this global mapping, we can all see that the global mapping has in many ways helped us to shine the light or point out to us some of these African countries that have some interventions that are specific to women who use drugs. And then it also shows largely that most of the African countries have no interventions per se that are specific to women who use drugs. Also, I believe from the mapping, we've been able to see for women who use drugs, and then for networks, organizations around the globe that work for harm reduction and for women who use drugs, we now see the gaps in programming, in implementation. We see the needs of women, you know, who use drugs, and how much more advocacy we need to put in place to actually meet up with all of these gaps. As we can see, of the many African countries, very few had services, and even the services that were provided were not necessarily the complete package or the complete services that a woman who uses drugs would actually require. So thank you all for listening. I've come to the end of my presentation. I'll hand over to Lynette. Thank you.
Thank you, Rita.
Yeah.
You mentioned inadequate funding. You see the gaps, you see the needs. How would it be if you were to receive funding to address these needs?
Okay, I would say inadequate funding. Even in the presence of more funding, we might not be able to, you know, cover up these gaps if we don't have proper structures in place, if we don't have capacities, persons who can actually carry out this programming, this advocacies, you know. So I think funding might not necessarily be the issue here. We would need more capacity being built, more specific messaging, you know, we need to do more advocacy around the kind of the messages that we are bringing out there. We need to change the narrative in a way before funding and, you know, other sponsorship can probably uplift like what we've started, like help us go along with the campaign, with the whole harm reduction for women. Yeah.
So before actually increasing service delivery, you'd need to prepare the ground and get the narrative sorted. Yeah, so the funding would need to go in that direction more so than actual service building. Great, thank you very much.
Thank you.
Our next panelist is Vielta from Eastern Europe and Central Asia. Thank you, Vielta.
Thank you for this opportunity. My name is Vielta Parhomenko, and I'm from Ukraine. I'm head of Klobany and member of Ukrainian network of people who use drugs and Eurasian network of people who use drugs. I can share situation with global mapping in my region. We got responses from these countries, from Belarus, Croatia, Georgia, Kazakhstan, Kyrgyzstan, Montenegro, Slovenia, Russia, and Ukraine. And these responses have some common accents because all in a context of punitive and discriminatory drug policy in their countries. And we have some issues in harm reduction programs for women who use drugs in this region. For example, it is like a choice in accessing services where women who use drugs exist. Also, a lack of shelter in situation of violence, child care services, social services, and psychological help from tolerance psychologists. Also, we saw a lack of treatment services, including OAT for women who use drugs. And we saw these issues, restrictions on employment opportunities, deprivation of parental rights for women who use drugs, and high level of stigma and discrimination from medical officers, police, and neighbors against women who use drugs. And I listen now this problem we have in whole world, not only my region, because we have really high level stigma and discrimination. And we have many problems, issues, and gaps because our harm reduction programs they develop for men who use drugs. And we have now clear gender sensitive harm reduction programs in this region. But we have positive cases, for example, methodology WHRIN in Georgia, Kyrgyzstan, Kazakhstan, and Ukraine of this region. It is women-initiated new goals of safety. It is methodology for women who use drugs in situation of violence. And this instrument included in harm reduction programs in this country and can help for women. So we have harm reduction services in this region for people who use drugs. Also, we have some peer consultants, strong activists of community of women who use drugs, but there are no gender-oriented harm reduction services. Maybe we missed some information. If you have, you can join in whole report on our site. So we need more services, more harm reduction programs with funding for people who use drugs. And we really need gender-oriented harm reduction programs for women who use drugs in all countries of this region. Thank you.
Thank you, Bjelta. Some similarities coming up between all the presentations. It's really interesting to hear from you about WHRIN as an example of a gender-oriented approach that is starting to operate in your region. Can you tell us just a little bit more about the function and the features of WHRIN and how you think it'll go in the future?
Yeah. It is a methodology of Columbian University, and I think a strong part of this methodology is about peer supporting, because facilitator of WHRIN's groups are activists of community of women who use drugs. And it is about peer support, peer help, and it is about help in this situation for right now, because women who use drugs, they have many gaps and barriers for overcoming gender-based violence, and they cannot exist of this situation because they use drugs. But methodology of WHRIN helps to women who use drugs be alive and be in safety in situation of violence. And I think that all harm reduction programs can include this methodology, because I believe in WHRIN and I see that it really saves lives for women who use drugs in my country and other countries of region.
Thank you, and thanks for including the link. People can look a bit further into it if they want to. Okay, thanks a lot, Bjelta. Our next panelist is Rhiannon, and she'll be presenting the findings from the North American region. Thank you, Rhiannon.
Thanks, Lynette. Hi, so my name is Rhiannon Thomas. I currently work at a harm reduction program, and I'm coming to you from Toronto, Canada. So for the first slide, just to give a little bit of context, and some of the what I'm going to say, of course, is information that we share amongst all regions, but particularly from North America, it's important to say that the war on drugs is ongoing. For women who use drugs, incarceration rates in women's prisons are rising quickly, and this is largely due to low-level possession and trafficking. This has direct impacts on women with children. If no family is available to help, they're put into foster care, and Black and Indigenous children are grossly overrepresented in that system. The legacy of colonization in North America also provides a context for health, justice, and social services, and where people who are Black and Indigenous are systematically receive either poorer treatment in the health and education systems and are specifically targeted by child welfare authorities and police. The impacts of those systems also means that women who are living with daily racism and trauma are continually pushed to the margins, and this is especially true for women who use drugs. And of course, women who use drugs have to hide their drug use to protect themselves and their families. The opioid poisoning crisis is also a very important context to remember in North America. Almost 23,000 deaths in Canada since 2016, and about 100,000 in the US in that same time frame between then and now. And this is driven largely because of criminalization of drugs and the rise in fentanyl and other powerful opioid analogs that are dominating the market with increasingly fatal contaminants and mixes. Where there are harm reduction service progress and successes, these are driven by people who use drugs, which would be no surprise to anyone who is on this call. Any interesting service that you'll read about in the report is typically conceptualized, developed, and often run by people who use drugs and women who use drugs. In Canada, there is some progress with federal funding around harm reduction services, which is great with our current government. Small amounts, but there is progress. One small drawback of this is that programs are kind of increasingly professionalized, harm reduction programs, and then run by people who don't use drugs and don't understand the realities for women who use drugs. And this means that, you know, women, folks who are trans, Black and Indigenous people end up being further marginalized and not included in the planning and the delivery of services. So for the second slide, key findings from the report and results from the mapping. So as I said, criminalization of drug use is listed as the top issue for women who use drugs to access harm reduction services. And this is going to continue to be a barrier to improving support. In both countries, the survey participants kept identifying the same key gaps. One of the major one is a lack of childcare and a fear of child apprehension and the stigma that's attached to that. And in general, there's a lack of female-specific services. In both Canada and the US, in general, harm reduction services for women are rare. And in rural areas, they're essentially non-existent. In Canada, in the past 10 to 15 years, there has been a slow move towards harm reduction for services for women who use drugs. These are largely in the major cities. They're not extensive and they're quite rare. One example of this is Sister Space, which is essentially a small decriminalized zone, a supervised consumption space in Vancouver, Canada. And when you walk in, it's relaxed, it's run by women. It's not a clinical feeling space, which typically in Canada, most consumption spaces are. And women can come in, legally consume drugs and access support, supplies, get referrals to other services and so on. Another gap is just in general, as some of my colleagues have mentioned, is just funding for harm reduction services. Another major result from the mapping is just generally stigma and discrimination against women. And this is in line with the dominant kind of patriarchal capitalist structures that guide how women who use drugs are treated. There's a clear need for gender-based services that are inclusive of trans women, that address mental health issues, homelessness, sex work, especially street-based sex work, and gender-based violence. The services should be informed and led by women and trans women who use drugs. And we urgently need support to be included for mothers and parents who use drugs without working in tandem with child welfare authorities. In the United States in particular, there are some states as well where there are fetal rights laws, and those coincide with the same states where no harm reduction services for women are found. And thank you. I'll go back to Lynette.
Yeah, thanks, Rhiannon, for a really detailed look at the situation in North America. When I looked at the list of services, in fact, although they're patchy and concentrated in less repressive states and provinces and so on, it actually is the longest list of services from all the regions that the mapping took place. I'm just wondering if you've got any thoughts about how this relative advantage of the North American situation could be used to improve things for women who use drugs elsewhere, and indeed in North America too, in these areas that just don't have the services that are needed.
That's a really good question. I think on the ground, when we're delivering services here, we constantly feel like more needs to be done and more needs to be provided for women who use drugs. But it is important to recognize that in North America, we hold a lot of privilege. It's important not to forget that. And I think one of the things that we can do is kind of use research about our services to provide, I think some of our colleagues have just talked about the need for data and for proof that providing these services is not only important from a human rights or health perspective, but also it's financially better to provide harm reduction services. So, venues like this are so important to share this information and support our colleagues globally.
Yeah, thank you. Yeah, some of that cost-effective research that was done on needle syringe programs, for instance, was very useful, very powerful when talking about delivering and expanding services. So thank you very much, Rhiannon. Our last but not least presenter tonight is Daphne, who's coming to us from Western Europe. So over to Daphne.
Thank you, Lynette. I represent Western Europe, and from what I hear and from what I read, there are not many differences all over the world. I mean, most women I see face similar problems. Western Europe has a wide spectrum between countries that have strict prohibition and countries that have a sort of tolerance. And although this happens, and although it is very dangerous for women who use drugs in countries like Bulgaria, let's say, or even Greece, where I come from, and Romania, etc., what I see is that the gender-oriented harm reduction services are very few and very far between, and not really specifically organized for women who use drugs. For instance, a woman who uses drugs may be homeless, incarcerated, needing legal advice and support, might be sex worker, might be mother with children who needs childcare, might be a mother without her children, more usual because children are taken from us, HIV or hepatitis C positive, a domestic violence survivor, and what we see is that many women take advantage of those other identities, and through them, they get some services that they should have gotten as drug users or people who want to withdraw from drugs, whatever they choose. we had responses from 8 countries. Huge the difference between those countries in law and in stigma and in the way women are women who use drugs are seen or treated. But what we see is that there's a huge similarity in the fact that no specific interesting services for women are there, for women who use drugs. Wherever there are, women use them. And what we found is that wherever they can, and women take the initiative and start peer-led little organizations like the Medicineres that are more about violence, or the Chemical Sisters, a small group in Italy, we see that they have huge response from the environment and from the area. And this shows that obviously harm reduction is not organized well for women. And whenever we come forth and we have the ability to really say what we really need and organize, we have huge response from our community. Women who use drugs are still invisible. We don't have services provided for us, and wherever we are, we have them, we use them. This makes me very, very happy about it. I mean, I think that there is hope for improvement. There is, we have already identified from what my colleague said before me, what women need, where women feel comfortable to really use the services. And usually we see that women want to participate. What else? The stigma in some countries is very strong. We see huge differences in the services provided. I mean, there are services providing, let's say, food every day and shelter. There are services that providing, I saw one in Germany, showers for twice per year. They open and they consider it harm reduction service and offering. Of course it is, but it's not enough. It's not enough. And what we usually see is that populist politics makes it very difficult for politicians sometimes to help. And we see that in an area that is really a disgrace, the way migrant women who use drugs are treated. They are totally invisible. In my country, in Greece especially, it's as if no migrant woman uses drugs ever. They are nowhere to be seen. And this arises from the fear of politicians or of populist literature, let's say, in the newspapers, and the fear that they will be accused that they spend the money to foreigners and whatever. So the needs are huge. The needs are huge. Even in Western Europe, even in countries that we see that the law has improved. And with this, I think I finished my small presentation.
Small but powerful, Daphne. Thank you. Interesting points that combine, and invisibility, of course, is a big issue you mentioned, and the fear, the political fear to do anything about helping women who need assistance. But contrasting this with where there are services, women use them, and where they're run by women with experience of drug use, they run well, and the women know what they're doing. So it's a really positive side to it. I was just wondering, what do you think would be, imagine like a crystal ball, what would be the outcome for women who use drugs if these services were brought to scale, services designed for women were brought to scale using a gender lens in Western Europe?
I think it would be a miracle. And it's not only because I wish it, it's because I can see women in drugs have many differences to the way men use drugs. And we've seen that they manage many times, if they have some help, they manage to be more useful for their environment, for their children, there is no reason to, what I say years and years and years, is that the cost of taking the children from the mother is much, it's huge compared to the cost of educating the mother and putting somebody there to help. Yeah. And make the mother who uses drugs able to, keep her children with her, with the support system. And I think this is what we're trying to do with our campaigns. Yeah. And the campaign that starts today, the 16 days against violence, because violence is not only being beaten up, violence is being denied the basic human rights.
Yeah, I think it's a strong theme, I think, coming through all the presentation, is it's people being denied their rights and being denied the opportunity to express their strengths and their abilities, just pushed back to the margins, as Rhiannon said, etc. So thank you all very, very much. It's been great to hear from you. And I'd like to actually hand over now to the audience, and if there are people with any questions, we've got about 15 minutes for question time. Could I say, if you're going to ask a question, please give your name and, if relevant, the organisation you're from or what your interest is in women who use drugs and harm reduction. Any comments about a service that's been missed off the list of services, keep that for later, because you can update that directly using the website. So let's just take questions now from you about the presentations that you've just heard. Thank you. I have a raised hand from Bimal Achara from Napud. Okay, Bimal, sorry.
Oh, thank you. Thank you. It was very wonderful and insightful presentation from all the panelists. I was amazed by, listening to them and the growth that has been done in the past couple of the years by the activists and by the donors. However, my question is, what methodology we use for this survey? 1. 2 is, I'm from Nepal and I'm the chairman of Napud, network of SL people who use drugs, which is recently formed. And in Nepal, there are 7 sites only for female, 100% sites only for female. But the tragedy is we are only able to provide 100% commodities, not shelter, not other things, not other educational things. So just 1 is methodology, 2 is how the data and how the information is collected. Like there is a genuine one or no?
Okay. Any panelist would like to answer that question? Methodology and how the data and information was collected.
May I?
Yeah, go for it. Yep.
So hi, Bimal. This is Nandini here. So this was a survey that we had conducted, and it was sent out to all the different networks and within our networks, and it was a survey, and we received responses. Like if you look at the Asia region, so you were asking about the methodology of how the survey was conducted, or because I couldn't hear you. You had I couldn't hear you in the middle.
Yeah, I think, yes, he was asking about the methodology for the survey. So
Okay.
the survey instrument that was used, how key informants were contacted would be.
Okay, so I think Lynette, could you please answer, because I was not directly involved with that part of the activity.
Ruth, could you fill in a bit more on that one? The actual
Yes, I
survey
could, but I
instrument?
think also Vialta or Rhiannon could, if either of you would like to pick up on that.
I can step in if you'd like.
Yep, thanks, Rhiannon.
So, so essentially each region had a focal point. So one person who, you know, searched for contacts throughout the region, and specifically targeted those contacts with the survey, and then collected those survey findings and helped sort of write them up. And we used I think it was SurveyMonkey, the website, to create and disseminate the survey and also collect the information back. And then, you know, all those survey results were used to put into the report that you can see directly on the website there.
Thanks,
That
Rhiannon.
answers the question.
The survey was actually conducted twice as well. We found in the first round that some people had misunderstood some things, both definitions of harm reduction and definitions of designed for women. So we had people writing back saying, yes, women come to our needle and syringe program, but there was not necessarily any design behind that. So we ran the survey again, being much more specific, and in some cases following up with particular services where their status wasn't clear in that regard. We also reached out through Twitter and a bit of desk review to fill in the gaps in the findings.
Hi, everybody. Am I audible?
Yes,
Sorry, yes.
So I think Bimal might have, some network related issues. So yeah, I am Sania Zara, and I am serving as the General Secretary for the network of Asian people who use drugs. I am the only female representative, and we are actually a new network. And we have like 11 countries, 11 different representatives. We have India, Vietnam, Pakistan, we have Philippines, Indonesia. So we are actually a new network, and we would be very grateful if we are involved or we have some kind of alliance to participate in the future. So I heard all the presentations, and I'm grateful that this was conducted and organized. Thank you so much.
Hi. Yeah, thanks for this comprehensive presentation, and then you took us through the worldwide in terms of challenges faced by the women who use drugs. So and yeah, actually, like we are from Myanmar, and then here are my colleagues, and then yeah, we also acknowledge that, you know, like there are a lot of limitations in Myanmar in terms of harm reduction services for women who use drugs, and then we have a lot in common. So we have a question that in your research, do you come across also services provided by for the ATS women who use stimulants, or are you mostly focused on opioid users? Thank you. And then if possible, we will also look at the report, and then, you know, like we will also like to translate it to Burmese language also.
Fantastic. Thanks, Pani. Yes, look, the survey didn't distinguish about types of drugs used. It was really looking at the other end, you know, it's at harm reduction services, but we are aware that there's a huge shortfall across the world. In some countries or regions more than others. It's more noticeable, particularly noticeable in Asia. There are very few services for people in general that address amphetamine use well. And I guess that's something that is particularly felt by women who use amphetamines, who are not accessing the services because they're not really relevant. They're not really accessible for women. There are a few exceptions. I know there's been some pioneering work in a couple of countries, but gosh, they're so rare. So we hope that the work, you know, being promoted now, the stimulant guide and training package that's come from that will start to affect that landscape in a positive way.
Also, yes, and then we really appreciate and inspired by your efforts too, the WHRIN efforts. So keep it up.
Thanks, Pani. Nanette, we have some questions in the chat box. There's one from someone at Women's Nest. Can WHRIN consider including the websites and links to the best practices, women-friendly harm reduction services that we can benchmark within the future? Yes, thank you for that question. We are actually trying to do that. If you look at the website on our Watchdog blog page, you'll see there are a series of interviews with different services in different countries, trying to draw out living examples of really good cases that other countries or even the same country can emulate further. So please check those out and share them as well. It's a growing group of accounts. I think we have on the website so far 6, and we're adding to that group, to that series over time.
Okay. Thanks, Ruth. I was muted, didn't help much. In the chat box also, there's 2 questions which are very similar, which is saying, where is WHRIN going to go with this? How amazing how similar the gaps are. So what are the next steps? Will WHRIN design advocacy strategies? How can others best share the findings? So that's another question. How would we like people to share the findings in order to bring about change?
I think, as Nandini mentioned, this is kind of a first effort to chronicle, to sort of document what is available in terms of harm reduction for, design for women who use drugs around the world. We were kind of shocked as we went through and started collecting the data at how we knew there wasn't, huge scaled up effort anywhere, but how sparse the results were a bit of a shock. I think it's really going to be, you know, certainly at a global level, this will be a useful document to kind of take to the table, and when there is discussion, as there increasingly is, there does seem to be more space in conferences and in, you know, in UN spaces around women who use drugs, to be able to put it on the table and say, okay, this is all becoming endorsed, but is thin on the ground. Hopefully donors will start to be more aware, and I think at country levels, you know, even at service level, harm reduction programs might start to look at writing in elements designed for women in their proposals. Having said that, though, you know, resources, as we mentioned before, are not everything. Some of the changes can be really low cost or even no cost when we're talking about having different times for women to come, or different spaces, different configuration, you know, employing women, having a balance in staff, particularly peer staff. So it's not necessarily a massive investment. It's about having that women sensitive lens in service provision. So yeah, there's kind of multiple ways this report, the starter, could be used.
I've got a question, an earlier question here about medical marijuana, cannabis sativa. I just wonder whether anyone would like to comment on that, or whether that's really something we might get back to Commissioner Nicole later with an answer. It's a little bit left of or outside of the remit of this report. I'm inclined to say let's talk to you outside of this chat, Nicole, and give people a bit of time, more questions about the actual report itself, if that's okay. We've hit 8 o'clock, so we've gone, well, 1 hour. We've already gone 1 hour. I'll just have a look at what's the new message. Oh, they're just congratulations. Congratulations are fantastic. Thank you so much. Does anyone else have a question or any more comments? We've still got people coming into the chat, which is interesting. We've just done our 1 hour. What do you think, Ruth? We don't seem to have any more questions coming in.
I'd really like to, I think, yes, perhaps we can wind up now. I'd like to thank you, Lynette, and the panelists. Amazing job. Thanks very much indeed. And thanks to those who joined. Please do grab the links from the chat box here to the different languages, versions of the mapping report, and they're also available on our website, but you can see them there if you want to grab them now, and please do share widely.
Yeah, I'll endorse that. Thank you so much to our 5 panelists. It's been great working with you. Thanks to the audience for joining us and your questions and suggestions. They'll all be taken on board. And can I remind you that the reports and the global report are now on the WHRIN website, and the link to updating if you find some service information that is lacking or needs change. This is a living document, and we look forward to all of you helping us to keep it relevant and useful. Okay, thank you very much. Good night.
Thank you for all. Thank you, Lynette, for great moderation and facilitation of this event. Thank you, Ruth, for
my pleasure.
Thank you, panelists and participants.
Okay. So good night
to everybody.
Thank you, sister.
Bye.
Bye-bye.
Bye, guys.
Bye. Bye.
Bye.